Good afternoon, everyone. I'm here to present a meta-analysis on dual antiplatelet versus single antiplatelet therapy in post-TAVR patients for stroke prevention. I'm Dr. Ralph Yap. I have nothing to disclose. In post-TAVR patients, there is around 1.7 to 4% risk of stroke in the first year of implantation. Antiplatelet therapy in post-TAVR patients are based on expert consensus and limited RCT data. Hence, there is ambiguity in antiplatelet therapy in the prevention of stroke in post-TAVR patients. This study aims to determine the effectiveness of dual antiplatelet therapy versus single antiplatelet therapy in cerebrovascular stroke prevention, and to examine the safety data of dual versus single antiplatelet therapy with regards to major and life-threatening bleeding. For the inclusion and exclusion criteria, only randomized controlled clinical trials were included, and those who have clinical indication of TAVR, and it should be single versus dual antiplatelet therapy. We excluded studies with any indication for anticoagulation. A systematic literature search was conducted through PubMed, Embase, clinicaltrials.gov, Verdin.ph, Cochrane, Medline, and the WHO International Clinical Registry from its inception until November of 2019. And the following search terms were used. Those journals that were randomized controlled clinical trials, published, and those who are in English language, and those who have full text that were available were included. So for the primary outcome, stroke and all-cause mortality at 30 days and at 6 months. For the secondary outcome would be major and life-threatening bleeding. This image shows the study flow diagram. A total of 8 records were identified after the search, and after duplicates were removed, a total of 5 studies remain. 4 records were screened, and 1 was excluded, which was an ongoing clinical trial by Najunis et al. At the time of the search, no partial results were available for review. A total of 3 studies were included in the quantitative meta-analysis. This table shows the description of the included studies. All of the studies were randomized clinical trials. All of the studies are open label, which has its risk of bias. Total population of the 3 studies was 421. The study with the most population is from Rideau Cabal in 2017, with a total of 222 patients. All of the studies had dual versus single antiplatelet. One study utilized ticlopidine as an alternative to aspirin. So for the primary outcome, the incidence of stroke in single antiplatelet therapy was higher at 4.7% compared with 1.9% in the dual antiplatelet therapy group. However, the p-value is not significant, with a p-value of 0.12. No significant heterogeneity was observed in all of the 3 studies. For all-cause mortality at 30 days, single antiplatelet therapy is lower at 3.8 compared with 4.7 in the dual antiplatelet therapy. P-value is not significant at 0.64. Again, no significant heterogeneity was observed. For the all-cause mortality at 3 to 6 months, it was lower in the single antiplatelet therapy at 5.7% compared with 6.6% in the dual antiplatelet therapy group. Again, p-value is not significant at 0.70. No significant heterogeneity was observed. For the life-threatening bleeding, it was lower in the single antiplatelet therapy group at 2.8% compared with the 6.1% in the dual antiplatelet therapy group. P-value is not significant at 0.11. For major bleeding, It is lower in the single antiplatelet therapy group at 2.8% compared with 4.2% in the dual antiplatelet therapy group. P value is not significant again at 0.43. No significant heterogeneity was observed. For the conclusion, no significant difference in the all-cause mortality at 30 days and at 6 months, but there is a trend towards lower all-cause mortality in single antiplatelet therapy group. No significant difference in stroke prevention between the two groups, but there is a trend towards lower incidence of stroke in the dual antiplatelet group, and no significant difference in major and life-threatening bleeding between the two groups. However, there is a lower incidence of major and life-threatening bleeding in the single antiplatelet therapy group. So, for the applicability of evidence, all of the studies included had a small sample size. All of the findings were not statistically significant. And based on limited data, dual versus single antiplatelet therapy in post TAVR patients should be based on bleeding, thrombotic, and embolic risk of the patient. Randomized controlled clinical trials are needed with proper blinding to have a more robust clinical recommendation. Thank you.